guys, so let's start abdominal examination. Okay, so when you're doing abdominal examination, what's going to happen? You will have general examination as well. General examination means you'll be checking the hands, for example, you'll be checking the face, eyes, and the neck, lymph nodes, and everything. So that is general examination, and then only you'll be doing the abdominal examination. So when you're doing the whole of the examination, it's going to be a time-consuming process, right? So if it is coming as a teaching station, so it doesn't matter, right? You'll ask your student what exactly he wants to learn, and accordingly you can teach him. But when it is coming as a combined station, you're not supposed to do everything. You'll be doing only a part of it, depending on what the history you have got from your patient. Okay. So let's go through this examination, and then maybe we can have a discussion on certain scenarios as well. All right. So patient is lying down. For abdominal examination, make sure patient is lying down. Lying down the flat couch. That's the main thing, yeah? So first is the patient status around the bed. You can check. Now, what are the things you need to check? First of all, you can check in the hands as well if there is any palmar erythema, if there's any doctrine contractures, right? Then we can check for peripheral cyanosis as well. You can check for capillary refill time as well. You can check for clubbing as well, Shamrock sign. So that's how we can check that. You can check for flapping tremors as well if the patient is having any hepatic encephalopathy, right? So these are the things that you can do when you're doing a bit of general examination, right? So all these things, whether it's flapping tremors, you have got peripheral cyanosis, capillary refill time, nails, nail bed, you can check Shamrock sign, you can check for palmar erythema, you can check for doctrine contracture as well. And maybe you can check for the pulse as well. Right. Then you go to the eyes, right? So what you check for jaundice and pallor. So you actually look, you tell the patient, like, I'm going to pull the eyelids down. You pull the eyelids down and tell the patient to look up. This time you're checking for pallor. Then you tell the patient that I'm pulling this upper eyelid, and you pull it like this and tell the patient to look down. And you're checking for icterus, jaundice. That's the thing, right? You can tell the patient to open the mouth and then turn this tongue, and you can see the downside like this. Roll the tongue out. So then we can comment on stomatitis and Yaphthus ulcer, right? In the neck, patient should be lying down maybe at 45 degrees. So you can check for JVP as well. And the lymph nodes. Usually we check for varicose lymph node, which can be a sign of gastric cancer. And where you check for left side, left supraclavicular lymph nodes. That's your varicose lymph nodes, right? In the chest, you can comment on the gynecomastia. You can comment for spider nevi. You can comment on loss of axillary hair as well. So what is it? This is your general examination of abdomen. Before you actually go to the abdominal examination, what you do, you go for general examination. And then only we're going to go for abdominal examination, and we'll be commenting on a lot of things, right? So if it is a combined station, you may not be doing this general examination because there is no time. However, if it is coming as a teaching station, then we don't mind. You can start with this part as well, right? So how the teaching stations are done, you build the rapport, you assess their knowledge, how much they want to learn, you explain them the procedure. Like in abdominal examination, we have got general examination, then we have got the examination of the abdomen. And you can ask your student, from which point you want me to start with? You want me to start with the general examination? Do you want me to start with the abdominal examination? And whatever they want to learn, you can go accordingly, right? However, if it is a combined station, you may not be doing this general examination. Okay. Then in the abdominal examination, what are the things we have got? We have got inspection, we have got palpation, we have got percussion, we have got auscultation. And usually the sequence is inspection, palpation, percussion, auscultation. However, in the abdomen, what you can do, before you touch the abdomen, it's always a better idea to go for auscultation. What I mean by that, do inspection, then maybe do auscultation, then palpation and percussion. That would be better. Because if you already touch the abdomen, what's going to happen? You will see the bowel sounds and all, maybe they are, you may be having different findings, right? So that's the main thing. So after inspection, just go for auscultation, then go for palpation and percussion. So inspection, what are the things you can comment? You can comment like if the abdomen is distended or not. You can comment on the umbilicus, whether umbilicus is centrally placed, whether it is everted, if there is any sign of any injury or trauma, if there are any scar marks of any previous surgeries or so. So these are the things that you can comment. Then auscultation, you just listen to the bowel sound. So where you're going to listen to it, just 1-2 centimeters away from the umbilicus on the left or right side, you can listen to it, right? And before you say there are absence of the bowel sound, make sure you listen to it for at least how much time? You listen for it at least 2 minutes before you say there are absence bowel sound, right? Then we go for palpation. First you go for superficial palpation, you go for deep palpation. And what I want you to do, just make an S kind of formation. So you're covering all the 9 quadrants of the abdomen, and where you're looking at the patient's face for any kind of tenderness, and patient should be lying down on the flat couch. Then the same thing you will repeat again, and what you will do the deep palpation as well. Okay, so if there is no tenderness, for example, superficial deep palpation, there is no tenderness. So you'll verbalize there is no tenderness on superficial palpation. There is no tenderness on deep palpation. So this is how you're gonna verbalize it. And then what you need to do, you have to feel for the liver and spleen and kidney and for the aorta as well. For the liver, what you do, you start from the right iliac fossa, because if liver has to increase in size, it's going to go down. So liver is on the right side, and it's going to grow like this. You start from the right iliac fossa, tell the patient to take deep breath in and out. When patient is breathing in, with your hand, you're starting from right iliac fossa, you go in. So then you leave it, patient is breathing in, you go in. And this is how you will see. Normally, you will not be able to feel the edge of the liver. That's normal. If you're able to feel, you might be dealing with a case of hepatomegaly, right? That's how you check for liver, right? Then you go for spleen. Spleen grows like this on the side. So still, it's on the other side, it's on the left side. But when you start palpating, you start from right iliac fossa again, and you go to the left side. Again, to palpate the spleen has to be at least 3 times of its normal size. Then only you can palpate the spleen. If you're able to palpate the spleen, it means you have got splenomegaly. Then you check for the kidneys as well, just to see if the kidneys are palatable or not. Again, normally you will not be able to feel there is, the kidneys are non-palatable. Then you can check in the abdomen as well, just to see if you have got any pulsatile mass. And what are you looking for? You're looking for AAA, abdominal aortic aneurysm. All right. Then what we have got after that, percussion. So now you, for example, you found the liver is enlarged, you got hepatomegaly. Then what you need to do, you need to find for liver span as well. You need to find for liver span. So, like in the chest, what's the sound like when you do the percussion? So is it resonant or what? If it is resonant, when you're going to go to the liver, it will become dull. Same thing, you start from down there as well. It's tympanic, it becomes dull. Dull, that's your liver. And then you can check it with the measuring tape, how much is the size of the liver. That's how you can do it. Liver span. Then what you do, if the patient has got abdominal distension and patient has got the fluid collection, then you can check for shifting dullness and fluid thrill as well. If it is minor fluid, go for shifting dullness. If the too much of fluid is there, you can go for fluid thrill as well. Remember one thing, guys, shifting dullness. So what you need to do, you need to check if the dullness is shifting or not. You need to move the patient. Now the question is, are we going to move the patient away from you, or are you going to tilt the patient towards you? Remember one thing, in the UK, whenever we move the patient towards us. Because in abdominal examination, when you're checking for shifting dullness, you might be having a patient who is very healthy, like very obese patient or so. So if you tilt the patient to the other side, they might fall down from the couch and all. So make sure always you tilt the patient towards you. So when you're checking the shifting dullness, you go to the opposite side, you keep your hand there, you tell the patient, ask the patient to tilt towards you. And then you will check if the dullness has shifted or not. If needed, if the fluid collection is more, you can check for fluid thrill as well. Another thing that you can do while doing abdominal examination, You can check for Murphy sign as well. That's for acute cholecystitis, right? So if your suspicion is that the scenario is going towards acute cholecystitis, so when you're doing the palpation, just do one more thing there. Just check for Murphy sign. So what happened is it's because of the gallbladder, patient will be in pain, right? So tell the patient, you just put your hands here in the upper quadrant, right upper quadrant, and you tell the patient to take deep breath. So what's going to happen, and you're pressing here on the right upper quadrant. So if, for example, while taking the deep breath, suddenly patient is just having pain and they just stop taking that breathing, it means the gallbladder, the inflamed gallbladder is touching your hand and that is giving pain to the patient, which means it's positive for acute cholecystitis. All right. And if you do the same thing, same Murphy test on the other side, on the left side, it's negative because you don't have gallbladder on the left side, but it's positive here on the right side. So it means it is acute cholecystitis. Okay. So now in the abdominal examination, are we doing the examination on the patient or are we doing it on the mannequin? In some station, they might be expecting you to do it on the patient. In some, they want you to do it on the mannequin as well. Right, so let's have a discussion and let's see the topics and then we will see. These are the 9 quadrants. So when you do the examination, guys, you do one thing, you just do an S kind of formation in the palpation. So you're able to cover every single quadrant. And where are you looking? You're looking at the patient's face for any kind of tenderness. Yeah. Now, these are the stations. There's a chronic diarrhea, intestinal obstruction, cholecystitis, ectopic pregnancy, heart failure, abdominal distension, and ARLD, alcohol-related liver disease. In these stations, they are expecting you to do abdominal examination. Obviously, abdominal examination teaching is also there, right? So, chronic diarrhea. Okay, so you don't have the mannequin, you just have the patient. Patient is presenting to you with chronic diarrhea. Chronic patient is saying, I've been having it for 3 months. You elaborate the diarrhea, right? So you ask about the diarrhea, what's the content, any blood in it, is it loose stool, and you do proper odipara, right? And any blood mucus in it. And whenever you have got a case of vomiting, you have got a case of diarrhea as well, you always ask for dehydration as well. That's the thing that you can ask. Your patient is 40 having diarrhea for the last 3-4 months. So you need to rule out so many differentials as well. If I need to keep the differential, these are the differentials that you can ask. Bowel cancer, IBD, diverticular disease, GI infection, hyperthyroidism, pseudomembrane colitis, HIV, IBS. There are so many things. Bowel cancer, if you're thinking, ask about general signs, symptoms of cancer, weight loss, appetite loss, anemia symptoms, lumps and bumps. Also ask about tummy pain. Ask about tenesmus. Tenesmus is incomplete evacuation of the feces. Another thing, you always have to ask, change, alternate bowel habits. If patient is saying, I'm having diarrhea for the last 3 months, how were your bowel habits 3 months before? Whether this patient has constipation. If yes, then alternate bowel habits is not a good sign. So these are things you can ask. Lifestyle and past medical history, family history is important. You can ask for smoking as well. You can ask for the diet as well. Diet, like if patient is having processed red meat and all, that will be the risk factor as well. Right? So routine blood investigation you can do in the GP. You can refer the patient to the specialist as well for further investigations, which includes colonoscopy. Right? If you're thinking about IBD, patient might have bloody diarrhea. And also you can ask for extra intestinal symptoms as well. Any skin problem, any joint related problem. If you're thinking about diverticular disease, what you can ask for? Fever, flu-like symptom, that's one. What else? Patient usually have the pain in the left iliac fossa. That's the thing. Patient will tell you that I've got constipation. They can have diarrhea as well. They can have constipation as well. Patient will tell you if I'm passing stool or if I'm passing wind, it eases my symptom. That's the main thing about diverticular disease. GI infection, mainly Shigella and also travel history. That is something that you can ask. Hyperthyroidism, you can ask other questions of thyroid. Pseudomembranous colitis, maybe patient has taken long-term antibiotics. HIV, sexual drug history you can take. IBS, not very important because I'm looking for the red flag differentials first. Or else you can go for IBS as well, like see what kind of food if patient is eating and then they're having diarrhea. And also I will be looking for celiac disease and Whipple disease as well. Like if patient is eating something related to gluten and then they're having diarrhea or not. So malabsorption differentials will be there as well. So this patient is saying, having diarrhea 3 months, and patient is giving generalized abdominal pain as well. Not saying the pain is here or here, but the pain is everywhere actually. Okay. So in this station, you won't have any dummy to do the examination, but what you will see, you will have the patient and patient will allow you to do the examination as well, right? And in this case, what you are supposed to do, I would say just do the inspection and just do superficial and deep palpation. That's it. You don't have to do anything else. Just a brief superficial and deep palpation. Sometimes they say patient have got pain in the left iliac fossa, but mostly the patient will say, I've got generalized tenderness. So when you're just doing this S kind of formation and doing the examination on the abdomen, patient has got tenderness throughout. That is it. And then you don't need to go for anything else further. Just go to the management and finish it up. You do not have mannequin in this station. Okay, move on. Then there is another one for intestinal obstruction as well. I'll come to it. Let's go for acute cholecystitis. Acute cholecystitis, patient is saying, I've got tummy pain. When you go a bit more in detail, because tummy pain, I'm going to do Socrates. This patient is saying it's on the right side, just below my ribs. Pain is here. Okay. Sometimes patient might say it radiates to my shoulder as well. All right. That's very much understandable. So in this station, with this much of history, I think you can ask for other question, any nausea, vomiting, any fever, loss of appetite, any abdominal mass if they have got, itching if they have got, yellow discoloration, jaundice if they have got. So you can ask all those associated symptoms and all. Quick past personal history as well. Then when you do the examination, what I want you to do, I want you to do the inspection of the tummy. Then I want you to do the palpation of the tummy, and please make sure you do the Murphy's sign, right? And it's going to be positive, which will tell you the patient has got acute cholecystitis. Yeah. How are you going to do it? What is positive Murphy's sign? That is in acute cholecystitis. You refer that where the patient stops breathing due to the pain when you touches the inflamed gallbladder. How you elicit it? By firmly placing a hand at the costal margin on the right upper abdominal quadrant and asking the patient to breathe deeply. Yeah. If the gallbladder is inflamed, the patient will experience pain and catch their breath as the gallbladder descends and comes in contact with the palpating hand. Put your hand here, deep breath, and the pain is going to be there. That is inflamed gallbladder is touching your hand. Positive for acute cholecystitis. So if you're done with this much, move on and give your management plan. Give your management plan, right? Management is obviously fluids, painkillers, antibiotics, and then a surgical referral. We'll see when the infection subsides, you might be going for acute cholecystectomy as well, right? So do we have a mannequin in this? No, you will be doing this much of examination on the patient only. You don't have any mannequin in this as well. Okay. Next one. Next one, you have got ectopic pregnancy. Ectopic pregnancy. So patient is saying, I've got pain in the left iliac fossa or right iliac fossa. You will elaborate. You have got pain. What you're going to do? You will do Socrates as well. Anything else? This patient will say, I've got bleeding as well from my front passage. Okay. Socrates, pain, bleeding from the front passage, young girl. So what else you do? You ask another thing. This patient says, I've been having some nausea, vomiting as well. And when was your last menstrual period? It was 6 weeks ago. It means she is pregnant and pain in the left or right side. It is what comes in your mind is ectopic pregnancy only. Risk factors for ectopic pregnancy would be previous ectopic pregnancy, any contraception, because whenever you have got a female patient, what else you'll be doing? PPPP question you can ask. So try to find out the risk factor as well. So in this station also, they are actually expecting us to do the examination. Do we have the mannequin here? No. You have the patient and they might be expecting you to do the brief examination. So what examination you will be doing again? You'll be doing the brief inspection and you will be doing the palpation. When you do the palpation, patient will have the pain in the right or left iliac fossa, depending on what the history they have given it to you, right? Then you can discuss the management as well. That shouldn't be a problem because maybe the product of conception will come out on its own. Sometimes you may have to give some medications like methotrexate, or sometimes you have to go for surgical options as well. Make sure you admit the patient and manage it accordingly. What I mean to say in terms of examination, inspection, palpation. Do we have the mannequin? Not really. You are doing it on the patient only. Okay. Another station is coming on heart failure. Sometimes the presenting complaint is shortness of breath, but there's a scenario where the presenting complaint is abdominal distension. Abdominal distension. So what you do proper OD-para, you elaborate about the abdominal distension, for how long you have got, is it getting worse, is there anything making it worse, anything making it better, anything else. Patient is having cough as well. Sometimes patient has got bloody cough, because in heart failure you can have pink frothy phlegm as well. This patient will have shortness of breath as well. This patient will give you swelling in the legs as well, which are very typical signs of heart failure. Patient has got past medical history of heart attack as well. Patient is on medication. Patient might not be compliant to the medication, and that's the reason patient might be heart failure. That's the thing, right? Now, so this is one station where they have got abdominal distension. And there is another one, as I said, there is another one which is intestinal obstruction, where also what you're going to have, you will have abdominal distension. So in this station, intestinal obstruction, and the station of heart failure, what's going to be there? You will have an abdominal dummy, abdominal mannequin dummy, which is like a mannequin of BLS. So that is the dummy that you will have there. So in this case, what you need to do, patient has got abdominal distension. So here in heart failure scenario, why this patient is having abdominal distension? Because patient has got heart failure, so fluid is getting collected in different areas. It can collect in the chest, that can be the reason of shortness of breath, can be there in the abdomen, that's why patient has got abdominal distension. It can be there in the legs, that's why patient has got leg edema as well. So what you need to do, I mean, you can go for a quick inspection, then maybe palpation. But the main thing that you need to do in this case would be, you need to check for fluid thrill. Fluid thrill, right? You can verbalize about shifting dullness as well, but when it is a mannequin, it will be difficult for you to do the shifting dullness. But what you can do is the fluid thrill. Now, will the mannequin, you will be able to appreciate fluid thrill. It may not be possible, but you will be showing them the technique on the dummy, and your dear examiner will be able to give you the finding. All right. So this is the station that you might be getting. It is heart failure, and presenting complaint is abdominal distension. And what you are supposed to find in this is the ascites. All right. And the management is obviously tell the patient to be compliant with the medication. We might be adding some more medication as well. And obviously telling the patient about water and salt restriction as well. So all the management of heart failure that you can do. And the other one that you have is alcohol-related liver disease. This also patient has got abdominal distension, and when you are asking questions and all, this patient is drinking too much of alcohol. Too much of alcohol. So this patient is also having abdominal distension. You need to look for ascites, and also this patient you will have hepatomegaly as well. And this case you will be again doing it on the dummy. That's it, right? So these are the stations you have got. Let's summarize everything. So you have a station on chronic diarrhea, which you will be doing the examination on the patient. You are just doing inspection and palpation. So what patient will have? Patient will have the tenderness, right? Generalized tenderness. Then you have got a case on intestinal obstruction. Here you are doing the examination on the dummy, and the patient might be having here signs of abdominal distension. Pain will be there, generalized pain. Cholecystitis, you can go for inspection. When you're doing the palpation, make sure you don't forget Murphy's sign. And it is also done on the patient. Ectopic pregnancy, again the diagnosis, and you have to do the examination on the patient. What you will be doing, just do inspection and you do palpation. When it is heart failure or alcoholic related liver disease, both are with abdominal distension. So the examination is done on the dummy. What you need to do, you can do inspection. That's fine. Mainly what you need to look for, you need to look for fluid thrill. Shifting dullness, you can verbalize fluid thrill. And in alcoholic related liver disease, you might be having hepatomegaly as well. And there is another scenario which you have got is for the abdominal examination teaching. There you might be starting from the general examination as well. So that is how you need to do. Teaching station, obviously you will start with the rapport building and you will always ask the patient what you want to. You will always ask your student what exactly you want to learn. And accordingly, you will be able to teach them. Okay. So that is the thing that you will have in abdominal examination. All right.